All right, so we had been talking about the tubular reabsorption that occurs. There is a visual on all of the materials that get reabsorbed in purple right there. So what you see, glucose, amino acids, proteins, vitamins, and we had talked about those in the initial filtration materials that are filtered out by that glomerulus. So most of these, all of these, get reabsorbed back into the system as good, recyclable, and usable products, okay? What you see down here in pink called tubular secretion are things that are maybe additional waste products that are coming from the blood vesseling system and get dumped directly into that filtrate as waste-based products without having to go through that filtrate or the blood plasma. Okay, let's talk about renal functional tests in the urine. Please make sure you know what a urinalysis is. Examination of the physical and the chemical properties of the urine that's there. It should have an appearance of a straw color or a light yellow color. And again, that all kind of depends upon the collection vessel that you're using. What you should not see, blood in the urine. Now, blood may be due to urinary tract infections or crossing over from the reproductive system. What we don't want to see is blood found in the urine that might be further up the vesseling system somewhere. So either number one from trauma, number two from kidney stones, but what we're really concerned about is called pyelonephritis, in which the actual nephron is damaged and it's allowing blood to leak through that glomerulus and into the collecting duct and into the urine. And that means that we've experienced extensive damage in that glomerulus, okay? A lot of times we talk about kidney infections. Kidney infections, and for the most part, bacteria does not retrograde its way from the ureters into, from the urethra into the ureters and back up into the kidney. It's almost impossible. Therefore, if we're talking about true kidney infection has to be delivered through that afferent arteriole into the glomerulus. And at that point, if it's rotating in the blood, we're going to consider it to be septic. Okay. Pyuria is pus in the urine. And again, we talked about pus is manufactured from the neutrophils that are attacking bacteria. And they're sacrificing themselves, making this leftover byproduct of pus. So it indicates that somewhere along the way, bacteria is overrunning the system. Okay? You'll also find that there are a number of odors associated with certain types of bacteria, the urea and the ammonia. You'll also find that there are certain food products that will provide an odor to the urine because of the amount of phosphorus that's found in them. Asparagus is one of them. Sometimes you see a color differentiation with beets. So some of these odors are very indicative of materials that are being brought into the body and then being eliminated as waste products right before your nose. Okay? Specific gravity is the amount or the density of the solutes found in that urine. We would like to see it down here in this range. However, it can range up into 1 point. And again, what is this a comparison of? Where's this number coming from? Distilled water that you go in and buy, go to Target, buy a bottle of distilled water, take the density of it, because it has been distillated, there should be nothing in it. 1.000 grams per milliliter. Okay. Osmolarity indicates how much water is actually in our solution. The pH will tell us, and there's the range, 4.5 to 8.2, but generally we find that it's mildly acidic. It also should be fairly sterile. So in an emergency situation, if you have to use it to debride an area, I know nobody likes to do it, but it can be done, okay? Chemical composition, again, 95% water, 5% solutes. Please know what's normal to find in those solids and what is not. So normal to find in the solids, to find in that urine, urea, salt-based components, a little bit of creatine, a little bit of uric acid, a little bit of calcium, magnesium. Now, you might see calcium and magnesium because these are fail-safe release valves as that mineralization in our blood begins to rise. Okay, not all of it can be absorbed, not all of it can be laid down in bone. Therefore, If we need to get rid of it very quickly, we can do that. Okay? Abnormal. You do not want to find these in the blood. Number one, glucose. That should all have been reabsorbed in the through tubular reabsorption. Number two, hemoglobin or blood. Albumin. That indicates ketones, bile pigments. This indicates that there is a tear somewhere in the glomerular system and that it's allowing that material to leak out into that proximal convoluted tubule. With urine volumes, normal volume, 1 to 2 liters a day, very clinical conditions that can cause additional output. We talked about diabetes insipidus. We talked about diabetes mellitus. And again, with diabetes mellitus, we're not necessarily talking about volumes, but number of voids. With diabetes insipidus, we are definitely talking about the amount that's being voided out because they're not making antidiuretic hormone to recycle the water in the system, and so they might be voiding out large amounts. So polyuria, excessive amounts. Oliguria, not enough being voided out. It generally means that either the kidney is not working correctly or your patient is heavily dehydrated. A means no or not. So this is no output from the kidneys. Kidney disease, dehydration, circulatory shock, or prostate enlargement. This is a very dangerous condition that will lead to azotemia, and it needs to be corrected immediately. There is our diabetes. We just talked about it. Diabetes type 1 and 2. We talked about the ADH hyposecretion. The changes in the urine volume will create issues with the sodium-potassium chloride loop, not allowing us to trigger neurological action potentials. Okay? With our diuretics, we need to be able to pull off a fair amount of water to be able to reduce the body fluids and the blood pressure in the system. Okay? Renal functional tests. We'll talk real quickly about the functional test and the renal clearance. So renal clearance is the amount or the volume of blood plasma that will be removed in 1 minute. And this basically indicates whether or not we're moving enough fluid through the system. Okay? I don't necessarily need you to know how this is calculated. What I do need you to know is that renal clearance indicates whether or not the kidney is functioning properly. That GFR, that glomerular filtration rate, will determine whether or not there is some kind of disorder of the kidney, because not being able to clear enough fluid means that either we're not reabsorbing, we're not secreting, or we're simply not able to pull the filtrate off. Okay? Urine storage and elimination, so this is the last part of this discussion. Make sure that you know, number one, urine is always produced. Produce continue. Now, that is if we are in parasympathetic mode. Rest, digest, and filter. If we are not in rest, digest, and filter, we are not producing urine. However, urine, and when we think of urine and we think about the elimination, about every 30 minutes to an hour, for some of you 2 to 3 hours, you have to run and eliminate that liquid waste. That doesn't mean that urine is only being produced during those times. It is being produced continually, and you have a very mobile, pliable collection vessel called the bladder, which allows us to build and build and build and build before we have to go and dump all at one time. Okay? Therefore, it does not continually drain from the body. It occurs when we allow it and when we trigger it. And again, that storage apparatus that's there allows us to be able to dump when we need them to. Major calyces, ureters, renal pelvis, ureters traveling down to this guy right here called the bladder. Okay? So you see the bladder right there. There are the ureters to the bladder and into what's called the spongy urethra. The ureters. Again, retroperitoneal. Make sure you know they are muscle extending from the kidney to the urinary bladder. There is a endothelial lining that is very, very delicate. And if you have objects like maybe calcified stones moving from the kidney to the bladder, it could be very, very painful. Okay. 3 layers, the adventitious, the muscularis, and the mucosa. Again, most concerned about the muscularis, although the mucosa has what's called transitional epithelium. It's one of the only places in the body that we find it. And it allows for the building and the extension of those cells off the wall. Lumens are very, very narrow, easily obstructed by stones. There, you see them right there. Look at how muscular this the ureter is, okay? Urinary bladder, also a muscular sac. 2 major muscles that are found there, and we'll talk about them in just a minute. Okay? When we talk about the 3 layers, covered by parietal peritoneum, just like the heart, just like all the other structures that are there, very fibrous, very protective in its nature, anchoring the bladder to the wall so that it's not moving around. The muscularis layer, the major portion of the muscularis layer is called the detrusor muscle. We'll talk about it in a minute. And the mucosa, or that transitional epithelium that extends as the fluid begins to expand in that collection vessel, rugae, allowing for a lot of expansion and contraction in that muscular layer, okay? Again, 2 muscles. First one is called the detrusor muscle. And the detrusor muscle is located in the superior aspect of the bladder, and it will continue to extend and extend and extend and extend until the point where it reaches the cutoff point of pressurization. When it reaches the cutoff point of pressurization, it sends a feedback loop to the brain that says, hey man, too much pressure. Baroreceptors are starting to get a little uncomfortable. And so your brain will go through the process of action potentials to then contract that muscle. Instead of allowing it to go through relaxation, 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 it'll then begin to contract the muscle to provide a superior to inferior downward force, excuse me, through the top of that muscle, beginning to push the fluid out of that collection vessel. Also, the trigone muscle, found on the floor and in the posterior aspect, because we don't want a lot of leftover residual fluid in there. The detrusor muscle will push down from S to I, but the trigone will push from posterior to anterior. And so what you have is a pushing of all that fluid to the anterior portion, the most anterior and inferior aspect where that urethra is, okay? Make sure that you know that the urinary bladder is highly distensible. That means it stretches a lot. As it fills, it begins to expand superiorly. Now, fluid does not drop from the top of the bladder into the bottom. The ureters are actually located in the inferior aspect on the posterior side, so that as fluid comes in, it begins to fill from the bottom to the top. And again, number of baroreceptors in there regulating the pressurization. And as that bladder becomes full, and right there you see the detrusor muscle and the trigone muscle located in the posterior aspect, right here, 1 and 2. Those are the openings for the ureters, and fluid begins to come in and it begins to fill from the bottom to the top instead of the top to the bottom, okay? There's the urinary bladder. And again, heavily connected to the reproductive system, especially in the male, not nearly as much in the female. We will discuss the compatibility of the reproductive system with that of the urinary system when we get to chapter 27, chapter 26 actually, okay? Let's talk about some of the clinical conditions associated. Probably the number 1 concern and fear of most people is that they will end up with a kidney stone. They are called renal calculus, okay? Your patient will call it a kidney stone. When you write it up in the history and the report of your patient, you'll call it a renal calculus. Okay. Most of these are made from some kind of calcium phosphate or calcium oxalate. Most of them, not all of them, but most of them form in the renal pelvis. if we have been flushing out the system, most of them will pass unnoticed. However, if we are not infusing that kidney with enough water, if we are not allowing for those nephrons to work the way that they should, you may end up with large jagged stones that are very, very painful because they're tearing the mucosal lining of the ureters on their way out, okay? Causes include hypercalcemia, dehydration, and that's a big one, dehydration. What? Dehydration. pH imbalances, too much acid in the diet, frequent urinary tract infections. Now, when we talk about a urinary tract infection, we're talking about from the point of the ureter back into the bladder and maybe a little bit into the urethra, but not up into the kidney, okay? Again, enlarged prostate will cause urinary, and what happens is the pressurization that feeds back, it's a feedback loop from the pressurization, the ureters into the urethra and up into the kidney, causing a back pressurization and not allowing fluid to flow freely out of that kidney. Treatment, lithotripsy, and again, pulverizing those stones with ultrasound, and they now have an internal process that can take care of that as long as it's somewhere between the bladder and the urethra. Up into the kidney, they will try and do it manually, exteriorly. However, it may not be real successful. Most of these, they wait to see if they'll just pass on their own. If not, if it's up in the kidney, somewhere between the kidney and the, or in the ureter, and we cannot get lithotripsy to kind of break that loose, they may have to go in and surgically remove it, okay? The urethra. Now, I'm not going to spend a lot of time in the urethra because we'll talk about the urethra with the reproductive system, but just make sure that you know,